Okay. So welcome everybody to the Social and Behavioral Sciences noon meeting. It's an online affair only because Hilton isn't with us in person. He's in KZN. It's lovely to have you all here, and we're very excited to have Dr. Hilton Humphries join us to give us what I think is a really interesting presentation around some fascinating, and I say that as a co-author because I'm very interested in what Hilton's doing, but I think it has relevance to a lot of those of us that work in social and behavioral sciences, but also more broadly in public health, insights in and kind of theoretical thinking that Hilton's been doing around decision making. And the work is focused on HIV, but I think it has relevance to other contexts and problems. Hilton is a senior senior behavioral scientist at the Human Sciences Research Council. He's based at their Center for Community-Based Research, the community-based research unit, and he's leading this behavior change unit, and that's where some of this work comes out of. Hilton's been working for a very long time in research, specifically around adolescent sexual and reproductive health, and is interested in decision making and applying human-centered design principles to health interventions. So, Hilton, thank you very much for doing this and for presenting this work. You'll present and then we'll have some discussion online after the presentation, and we can take it from there. But thank you. I'm going to turn my camera off, but we can see your presentation and we can see your
I'm
your
just
face.
doing a
Hi,
I'm just
hi.
doing a quick hello so that you can see who it is. I was just saying earlier that my internet has been unstable, so I won't keep my camera on for ages. Also, I'm looking at a screen that's in front of me, but my camera is to the side, so it would be really awkward. You would stare at half my face the whole time. But
Nice
good
to
to
see you.
but good to see you, and thank you for having me. It's always, I'm going to switch my camera off now, but it's always super awkward to hear yourself be introduced. But nonetheless, it's all true, I guess. So thank you once again for having me. And I am very excited to share some of the work that we've done. And like Lucia had mentioned, she's been a co-author and a very important influence on my thinking. And so it's great to have her here as well. What I'm going to talk to you about today is the HIV decision-making cascade and integrating behavioral insights into HIV prevention efforts. And let me just see that it's changed my slides. There we go. So I'm pretty sure that I'm preaching to the converted when I say that we all know that sexual and reproductive health issues remain a critical global public health issue, and this includes HIV infection, other sexually transmitted infections, as well as early and unwanted pregnancies. And in response to this global pandemic, we have seen the development and rollout of many biomedical technologies that are aiming to be better suited to user preferences. So in addition to expanding the options that are available to potential users, we've also seen interventions that aim to increase accessibility of these interventions to the people who need them. And this has been done with varying levels of success. The one thing that's been underutilized or not fully appreciated, I think, is this need for a greater engagement with the decision-making processes that users have to go through in order to decide to use the products or services that are available to them. And this is done despite there being a strong evidence base from the behavioral sciences. What I've also found often is that when we're designing interventions or when interventions are rolled out, there's this underlying assumption that one, health is a priority for people, and so that they should want to be healthy, or they should be wanting to think about their health, or they should want to be doing all that they can to make sure that they're healthy. And also this underlying assumption of rationality in terms of, if we as healthcare professionals or interventionists explain to someone why they should want to take up something, that they should then do it. So the three pictures on the right-hand side of the slide there just sort of just remind us about the reference points from which a decision is made, or from which the different reference points from which health is thought about. So on the top, we have the healthcare professionals. So for healthcare professionals thinking about it, often considered more objective, not always objective. Their subjectivity comes into it. But, I'm explaining something to someone, I'm giving them the best advice, they should listen to me. They should be doing the thing that I'm advising them on. From the client's perspective, though, or from the user's perspective, they might be thinking, oh, I have to use, taking up something like oral prep means that I might jeopardize an important relationship. It might mean that people think I'm engaging in risky behaviors. And so is it going to be the best thing for me to do? And then from a social perspective, what implications does, it have? What will my family think of me? Am I transgressing sort of important social and gender norms? And so, the social influence on our decision making is integral as well. So we hypothesized a decision cascade, and it's using an analogy from the fields of HIV prevention and treatment, but also building on previous seminal work that's been done in both the HIV prevention and treatment space, but also in the space of user research and marketing. So there's 6 steps in this cascade. And at each of the steps, a person can fall out. And so if they fall out at each of the steps, or any one of the steps, they then have to re-engage in a decision process. And so they have to be cued to action, or cued to think about the action, or cued to retrieve information about the action that they are being asked to complete. They will then have a reaction to it. They will then evaluate whether or not the action is worth doing, what are the costs and the benefits, whether or not they have to assess their ability to execute the behavior, and if it's the right time to execute the behavior. If all of those things align, a target behavior will be completed. If not, a person will then fall out at each or one of the steps of the cascade, and then have to re-engage in the decision process at a later stage. So this is how we conceptualized it, and this has recently been published about a month ago. So I'm going to talk through each of the steps briefly, and just provide on the right-hand side there a sort of example of how it works in most cases. But the first step is this cue to action, or this cue to think about the action. And this is usually triggered or precipitates the decision to think about the behavior. And should I be doing this? Should I be, am I going to continue in this cascade of even thinking about making this decision? So this trigger can be external, so something environmental. So you go to the clinic and the person says, we have an HIV test, we're going to, we can do it for you today. So that's an external trigger, or an internal trigger. So maybe you're questioning, you have concerns about your partner's fidelity, and so your mind sort of thinks about whether or not this is something you should be doing. So for instance, going to have an HIV test or using oral prep. So many people will think that providing informational cues if we provide informational cues, a person will be pressed to act. But this isn't always the case, because the information we process, or the information that we listen to or that we take in, is influenced by several sort of biases and attentional blindness as well. We also assume that a rational explanation, so if we provide someone with an explanation about why, you don't know your partner's status, you should be on PrEP, or you should be getting an HIV test, we assume that this rational explanation will motivate use. This isn't necessarily the case either, because there's hidden costs and benefits from the reference point of the individual having to make this decision. Our minds, like I said, will filter out information. We only have a limited capacity to what we can pay attention to and what information we can take on board. And so we tend to look at what is perceived as most relevant to us, or the things that we want to pay attention to. If this is an attentional bias, and the information that we filter out or that we don't listen to falls into this sort of attentional blindness realm. So, for example, objectively, a person may be considered at high risk for HIV infection, but informational cues may not work if a person does not think of themselves as at high risk, because they will not pay attention to those messages. They will filter it out. They'll say, I'm not at high risk of HIV, so I don't have to pay attention to this information, and so I'm just going to ignore it. They may also seek out information that confirms that they are at low risk. So, oh, well, I'm cued to act, but this information is not important to me because MSM, so I don't have to pay attention to this. So they may ignore information that suggests high risk, and they also may recall reasons for their low risk more easily than counter arguments. If they cue to action and they think there's this level of importance placed on it, they'll then move into the next step of having a reaction to it. The reaction falls into the seminal, it is informed by the seminal work that was done by Daniel Kahneman when he thought about how our decision-making processes work. And the system one thinking is sort of a fast, automatic, sort of unconscious process, whereas our system two thinking is a more slow and sort of considered, deliberative process. And what we do is we will have this sort of unconscious reaction to thinking about a behavior. And it is affected by the associations our brains make with the action, and this will determine how we think about it. So it's this gut feeling. And even if we have a gut feeling that makes us uncomfortable, if we try to sort of, be more deliberative and think it, why this gut feeling is wrong, etc., it may still end up making the action feel wrong and therefore unsustainable. So these associations and then our reactions, these associations would determine our reactions, for instance, will also be affected by sort of the cognitive biases and heuristics at play, and it'll affect how people process information. So, for instance, we may recall negative information more easily. So we hear about an HIV prevention, we recall that HIV is only for people who are engaging in sort of what they may consider sort of deviant behavior or being sexually promiscuous. And so if you recall those examples most easily, you're going to have a very negative reaction to anything related to HIV. You may also seek out information to confirm your low risk. So I don't have to engage in this reaction. I'm going to have a negative reaction to this information because then it implies that I'm not low risk. And also a person may not meet the prototype of what they consider at risk. So they may have, like, a person who's at risk is a promiscuous person. So anything related to HIV is going to have a negative feeling associated with it. This can lead to apathetic, sort of negative reactions to HIV prevention messaging, and this will be regardless of what information is provided or available or how it is delivered. So again, on the right-hand side, if HIV prevention, these unconscious sort of negative associations with HIV can cause discomfort. HIV is often linked to negative outcomes. It can imply that you are having relational problems. It can also link to perceptions of mistrust and be associated with stigmatization. So this negative reaction may push the person out of this decision cascade at this early point. If they continue in the cascade, they will then move to the sort of evaluation phase. And this evaluation step is more of the system two thinking, if we were thinking about Daniel Kahneman's way of how the mind works. It's this sort of conscious deliberation and evaluation of the action, where we think about what are the given costs and what are the given benefits of conducting or carrying out the targeted behavior. I think I can't stress enough this process of evaluation is very complex, and it's mediated by sort of numerous subjective evaluations that are made from an individual's reference point. So the costs and benefits that a person will associate with completing a behavior are evaluated by them and will be important to them. The costs and benefits of me using oral PrEP, for instance, may be very different to the costs and benefits that are important to one of you. And so this will determine how I decide whether or not this action is worthwhile carrying on. And that is the reference point. It's the baseline from which I'm making this evaluation. Again, this evaluation is sensitive to biases and beliefs, and this may come across as irrational if you're thinking of it from a perspective of an interventionist or as a healthcare professional. You might be thinking, well, why won't this person? They don't know their partner's status. Their partner is a migrant worker and he's only comes home every 3 months. This person should be on PrEP. They should be thinking about the HIV prevention. But in terms of a person who's is saying, well, the costs of this is that I may imply to my partner that I don't trust them, is really a cost that is too much for me. So I will not do that. It's not worth the potential loss of a partnership. And so that cost may outweigh any benefits that you may provide to the person. It's important to remember for this evaluation that, like I said, the costs and benefits are subjective. The information that's used to make these evaluations is mediated by what source of information people use. So the source of information may be the phenotypic characteristics of your partner. They look healthy, right? So if my partner looks healthy, it means that they should be fine. They can't possibly have HIV. People with HIV are diseased and have sores. It may be also by perceived biases. So if you are going to a healthcare worker or an interventionist working some NGO, they may perceive that the information you're giving them is biased towards making them want to, like that you have to do this. This is your job. You know, you paid if you get people to do this. So there's bias from a healthcare perspective, and the trustworthiness of the source. So what information is most believed. Often people will believe their peers. Often people will believe voice notes that have come through WhatsApp, and they will favor those over other sources of information which they may feel is compromised. We see this particularly in the political arena at the moment, where information sources are considered, non-objective, and people sort of explain a lot of, even when called out and shown that this is incorrect misinformation, people will still find reasons to believe it. So and I think social media has a very important role to play in the information we believe and the information that we don't, and our algorithms are sort of just acting in a beautiful way to confirm our biases. The need to assess or get further information is also subjective. Maybe people think, oh, I don't need to get any more information. I have enough to make this decision correctly, and affected by the motivations that a person has. Finally, the action that needs to be taken or that you are suggesting or that they're thinking about needs to be better than the alternatives that are available and worth the effort, and in which case a person will then continue in this decision cascade. So an example on the right-hand side, if a person assesses that PrEP use could potentially jeopardize an important relationship and believes their partner is HIV negative based on phenotypic characteristics, the conversations they have with the partner, or that there's a sense of trust, which is fundamental. If we want to have healthy relationships, we have to at some point jump off the cliff and just trust the person. The alternatives of accepting the trustworthiness of a partner and avoiding any relational strife would be preferable to maybe seeking out HIV prevention services. If the evaluation is made and it's considered worth doing, a person will then also assess the ability to do it. So it takes place after an evaluation of the decision to act has been made and involves this assessment about the actual feasibility of doing so. And there's several sort of concrete steps that we need to think about in this realm of ability. Firstly, a person needs knowledge of what is required. So they need to know where, they need to know when, they need to have how, they need to know what is able and what's available and how do they access it. And so if we have interventions that are focused on accessibility issues, those may be really important here, right? So the person's decided it. If it's coming to their doorstep through a CHW intervention, that might be a great way of getting them to do it. Or if they can get to their clinic, they have to go to their clinic, they're going to have to assess whether or not they have the resources to do so. It takes us to the next point, that the resources are also critical for action. And even when an action is considered worthwhile, without resources, it would be unfeasible. So a person may evaluate, they may be cued to action, they may have had a sort of positive reaction to it or an apathetic reaction and still continue. They've evaluated it having importance and that they should do something, but they don't have the money to travel to a clinic to do so. Or they don't have the mental resources to deal with this potential stigma that may come out of it. And so they decide not to continue. They don't have the ability. So again, interventions focused on making it available. So for instance, cash incentivized programs may be really useful for here. Different sorts of modes of intervention delivery could be really important here to eliminate some of those access issues. And then a person must also perceive themselves to have the skills and self-efficacy to act successfully. So interventions that are looking at skills development, that are looking at bolstering people's self-efficacy beliefs, that are helping them to negotiate with partners, etc., these may be really important interventions at ability. So a lot of HIV prevention interventions have a strong focus on improving a person's ability to use HIV services. But in doing so, they exclude users who may have dropped out earlier in the cascade. So it's also, these are people who have thought about it and seen the importance of accessing an HIV prevention intervention, for instance. But this excludes people who dropped out at the Q stage, right? So people who may not consider, who are objectively at risk, but don't consider themselves to be, or people who would benefit from using an HIV prevention resource, but don't see the point of it. And so they're not even engaging in the intervention in the first place. They're not even engaging in seeking out information. They're just saying, it's not for me, I don't have to worry about it. So once they've assessed the ability, it's this idea of timing. And so we often don't think a lot about timing when it comes to interventions. But if a potential user feels a need for HIV prevention services, the action is appealing, it's assessed as feasible, we still need to decide when to act. And this is mediated through a sense of urgency. And this urgency can come from it can be both external urgencies or an internal feeling of urgency. So an external urgency might be, you've found out your partner is is having sex with someone else on the side. So there's this external pressure to now you have to act. I have to do something about it. It's urgent. I need to do it now. I need to be on PrEP right away. Or an internal urgency. So you may, for instance, if we're thinking about treatment, it might be that I'm having some symptoms that are related that I think could be HIV. So I need to sort of go and find out about, I need to go have an HIV test. So these are sort of external senses of urgencies that are making this action very important, or internal feelings of urgency that make the action important and necessary to do. If it's not perceived as urgent, someone may delay the service engagement. So they have considered that all of these things are important. They do think it's important to do, but it's just the wrong time to do it. They don't have time right now. And so what will happen is then when they will fall out of the sort of the decision process now and have to initiate a new decision process when they next get queued. So someone says, I think it's really important that I use oral PrEP, but I can't go today because I have to be at work. So I'll have to put it off. And so when next queued to action, they will go through this sort of decision process again. And if it's the right timing, continue to go and seek out the services. Useful interventions is like commitment devices. So getting someone to commit, it's shown to be quite a strong sort of behavioral intervention. Supporting motivation to act or continue to act, and supporting habit formation is important at this stage as well. So if we expect someone to take their pills every day, habit formation is a very powerful tool to get someone to sort of initiate that behavior, but then also format it into a habit that then cues the sort of decision process much faster. If all of these things are done, so action is considered important, it's feasible, correctly timed, a person will then execute this behavior. And I think, again, just to hit home, and it might sound like a broken record, but we should view each of these steps from the perspective of the decision maker and understand that they will only continue with an action if it's more effective or preferred to what other alternatives are available. And again, an example there on the right-hand side. If seeking HIV prevention services results in questions about trust, a person may default to dismissing concerns about partner fidelity because it results in less cognitive distress, making HIV prevention service use less attractive and reducing the perceived urgency of initiating it. So some considerations to think about with the decision cascade, and I mean, I think we will collect data and use this sort of framework to look at how we think about decisions and make adjustments and adapt it as it's necessary. But as it stands now, it links logically to existing HIV prevention metaphors. And what I think is important, like I mentioned earlier, is that it doesn't only sort of think about those who are in the clinics or those who are in the interventions already and their decision making around product use or why they're continuing to do, adherence or those sorts of factors. It thinks about all of the different people falling out at the different stages of making a decision. So those, like I mentioned earlier, who are not even paying attention to the information that's being provided because they deem it not necessary, even though it might be. How do we get them to think about it? Or people who feel that they may not have all the necessary ability factors to do it, or may evaluate it, or we're using subjective information that may not be in their best interests. How do we intervene? So while earlier, it's also to think about the earlier steps occur with little conscious thought and the later steps require more sort of conscious deliberation. But it requires maybe thinking about what interventions would be most useful at the different stages a person finds themselves in this decision process. So we have in the behavioral sciences, very good evidence, although mainly coming from from the West, is around what behavior change techniques we have and what mechanisms of actions underlie behavior. So what mechanisms of actions and behavioral change techniques would be best used at each of these steps in the cascade to push the person to make the decision that is best suited for them or best suited for their health. It's also possible that the steps may not always act sequentially and may interact with one another. And so an example there is a reaction may change or take place again after a choice has been consciously deliberated. So initial negative reactions to oral PrEP could be overcome when someone hears that there's other available PrEP options. Whether this is a completely new decision process, that may be the case, and that's what we're going to investigate. And then while factors relating to ability and timing, and then also factors relating to ability and timing may also inform the evaluation of taking the action. So economic costs of accessing services may then inform the cost-benefit evaluation. So I understand that for many, the decision-making process may, hark back to psychology and the sort of individual focus that often characterizes psychology. But I don't think that this perceived individual focus is an accurate criticism. The steps and each of the steps that a person goes through in making a decision are influenced by a broad range of sort of ecological factors that exist both from the individual in their sort of immediate surroundings and then in their larger sort of context or contextual milieu. But ultimately, where all these factors come together, an individual is required to make a decision and eventually act. And so we have to support those individual decisions. So in conclusion, this cascade highlights different types of decision makers, and it doesn't only focus on those who are already in the system or those who may have some sort of perception of risk. It's thinking about those who aren't thinking about, it's thinking about who's not being cued to action. It's thinking about people who aren't thinking about their health. It's thinking about people who don't never think about HIV at all. How do we then intervene and how do we start thinking about intervening with those people in particular? It can also be used to understand once-off decisions. So, for instance, if someone's undergoing a procedure like BMMC, that would be a once-off, and the decisions surrounding that. Decisions to initiate complex behaviors like using oral prep or using the vaginal ring or lenacapavir when it hopefully becomes available, as well as continual simple decisions. So, once we've got someone on prep, they still have to take that tablet every single day. So how do we support those sort of continual simplest decisions that they have to make? So for instance, someone may use prep, they start taking prep, they develop side effects. That's going to change the reaction step or how they react to taking prep, because they're going to be like, oh, I feel nauseous every day. This is not something that I like to do. And so my reaction becomes negative, and I may stop taking it, and then my adherence will go down. So how do we just support like getting someone through that process? The cascade also highlights the need for interventions tailored to support each step in the cascade. And like I mentioned, thinking about which mechanisms of actions and which behavioral change techniques would be most effective at these different stages. It provides a useful research-supported visualization it facilitates the conceptualization of the decision-making of decision-making as a process that is continuously happening for potential users. And I often find when I talk to colleagues that people think, if someone is using PrEP, it's this decision to use PrEP, and that's where the sort of decision ends. It's like, oh, I've decided I'll use PrEP, and that's the end of it. But once you've used PrEP, you have to decide to continue to use PrEP. You have to continue to be happy to take it. It's a long sort of, hundreds of decisions that are made every single day around carrying on taking, having to continue to take PrEP, or deciding to use something else that would be better suited to you if PrEP is not working for you. So it's this continuous process, and so a very complex, process that may require different interventions depending on where a person is. There's also scope to apply it beyond decision-making for HIV prevention. So I think for HIV treatment, other sexual and reproductive health behaviors as well, and hopefully broader into, uptake of, for instance, apps that are becoming really important, technological or digital decision-making. And also it frames continued behavioral actions, recognizing the difficulties that users face when deciding to act. So again, it's from this reference point, people use the particular information that they think is best to make this decision. And there's a lot of difficulty that comes in with making the right decision and going with it. So I think it's a really helpful framing tool for that as well. And that is it. Thank you.
Thanks, Hilton. That was great. Very clear. And so we have lots of time for conversation and discussion. Like to raise their hands. We put comments and questions in the chat, but if it's possible, using your microphone, then that's also a nice way to interact. Devorah, go ahead. Thanks.
Thank you so much, Hilton. My name is Devorah Davey, and I'm an epidemiologist at UCT. And I've been doing research on PrEP in pregnant and breastfeeding women in the Western Cape. And recently, colleagues of mine have developed a shared decision-making tool to really improve PrEP counseling with the provider. And so I'm wondering, in your cascade, which is really interesting and well developed, where the role of the provider is. And I think in our research, we found that the provider is really key in determining PrEP initiation and continuation and supporting pregnant women to continue. And that's why we've decided really to engage in this shared decision making where the provider assists the participants, or the woman, in deciding when, how, where to take PrEP over time. So wondering more about the engagement with the provider and how that could work into your cascade. Thank you.
Thanks, Deborah. Go ahead, Hilton.
Okay, thanks. I think, Deborah, you, if I'm not mistaken, you work with some colleagues of mine. So Zainab Essek, I think, is working with you.
I do. Zay and I work closely together. We do, yes.
I heard your name and I was like, I don't know how many Deborahs there are, so it must be
Just
at
me.
UCT, so it must be very,
Yeah,
I must be striking out. I must be lucky there. Yes, I think ultimately, like I was saying, I think this decision, the role of the healthcare professional or the role of the interventionist is to support the person in making this decision. So I think that those shared aspects becomes like I'm facilitating you through thinking about, the processes of what is your ability to do this? Like, how can you do this? Are you, what costs and benefits are important to you? But I think where it's important, the role of the healthcare provider is not to sort of, say, it's these are the important, oh, that cost is, oh, that's not a cost, oh, you should be able to overcome that. Oh, that's a minor thing. You can keep this hidden from your partner, etc. It's not to sort of underplay those subjective costs and benefits, but to help someone come up and help someone maneuver through the decision cascade by using those subjective costs and benefits that are important to them to make an intervention that is sort of tailored, or a decision process that is going to work for them in their actual lived experience. So I think it's, for me, how I think about that interventionist or the healthcare professional is one in facilitating the role and helping that person to consider all the sort of important information that would be needed to move them through those steps and sort of like hold their hand, but make something that is relevant to them. Sort of don't downplay it as being like, oh, well, that's, like I said, healthcare professionals will often be like, oh, this person's being irrational, or that's not important. You should be able to overcome that, but rather sort of think about the importance, subjective value that those factors have.
Thank you. That's really helpful.
Thanks, Deborah. Next on the Kate Berg, you have your hand up. Welcome.
Yes, thank you. Hi, I'm from the Medical Research Council, and I'm doing my PhD on HIV prevention cascades with Ilona Tosca. Thanks for your talk, Hilton. It was super interesting. I have so many thoughts, so I'll have to streamline them. But I'm using quite a different cascade. It looks at motivation to use, access to, and effective use of HIV prevention methods. And I think the thinking for me is that we want to simplify the cascade as much as possible so that more people adopt the same cascade and we can promote comparability across different populations, geographic areas, and programs. So I'm just wondering who you imagine will be using this cascade. For me, I think the cascade would be used mostly by kind of programs and evaluations of programs to track key indicators. So kind of keeping it simple is key. So yeah, I don't know what you think about that. And then I also just wondered if there are set standardized measures for the different steps of your cascade that already exist, and whether these are things that would be easy to get from routine data sources.
Yeah, thanks, Kate. I don't know you, but it's very nice to meet you. Yeah, I mean, I think that there are several. I mean, when we envision or come up with new ideas about how things work, it often comes from the sort of missed opportunities you see in other things. So when I was looking at, I've thought a lot about how people make decisions in HIV interventions, in particular HIV prevention, because that's where I've worked my entire life. And you think to yourself, some of those failings of these other processes is that it's looking at people already to some degree who are engaged in a system. So there's already some, it's people who are already thinking about their risk, already thinking about their health in some regard, and already thinking about what they could do to mitigate some sort of risk. Whether or not the success of going through the process or whether or not it's best suited to them is then a different conversation. But there's this sort of primed ability to or priming to think about their health, what the motivations are different. And it got me thinking about, well, there's so many people who don't think of health as a priority, or health is often, thinking about health can be often a luxury, right? You have to take a whole day to go to a clinic. You have to take time off to go and, just to be healthy. Eating healthy costs so much money. All of these things are very expensive. And so in many ways, health is a luxury. And so I was trying to think with this cascade is, so how do we think about the people who aren't engaging in these, they're not thinking they're at risk. They're not engaging in any sort of thinking about whether or not they need an HIV intervention like PrEP or treatment, or if they need to be in treatment or any of those cases. They're not even sort of at that step. And that's what's missing. And so for a lot of interventions, I felt that it was preaching, or it was talking to people who had already sort of prioritized their health in some way. And so how do we think about the people who are failing, that we're not reaching, who are not engaging in interventions, who are not coming to clinics, who are not assessing any sort of risk, or not paying attention to, the sort of messaging. And so that's what bore this sort of cascade out. And then to think, how do we think about this decision process from the individual? How do we think about this, all those sorts of steps that they have to, all the sort of decisions they have to take, and all the things they have to think about that are not necessarily, that aren't necessarily being addressed by the interventional components that we may think is important, or that interventionists think are important, or that policy may think is important. And how do we take it back to the reference point of the people having to use these things and make these decisions? And how do we get it to be more responsive to those needs? And I think that's what this cascade is trying to add to the field. In addition, in terms of indicators, I think that's an important next step for us, is to be like, how do we develop indicators to measure these things? And how do we get people to make it easier and fluent, so that people will use it, and that people will take it up? So I don't know if that entirely answers your question, but if it doesn't, you can welcome to follow it up with another one or an issue of clarity.
No, that's great. Thanks. So I wasn't sure if you had already developed the indicators or if you were still in the development phase. But...
No, that's to come. That's to come next.
Okay.
Thanks, Kate.
Thanks, Kate. Alex, you've got a question.
Yes, hi, and thank you, Hilton, for great talk. I was just wondering if I'm sure you have thought about, but incorporated sort of the different sources of information that kind of plays a part and influences an individual along the decision cascade, and if sort of the influence or impact of those information, whether it's sort of through a conversation with a partner or on social media or, messaging in any other form, if the influence of those sources kind of differs along the decision cascade.
Yeah, so I do I think information is a critical element. It's one of those things that are, what's it, necessary but not sufficient. Like, you have to have the information, but it's not sufficient to drive behavior. And I think it will have a different influence in the different stages of the cascade, depending on where you are in the cascade. I suppose the information that you're using to make the decision, or that's informing the decision, will have an important influence. So, like you were saying, if you think about it right in the beginning, if you're looking at the reaction that a person would have to sort of HIV messaging, that would be informed by the information that they have received, or what they think, what they think about HIV, and therefore, what information that they're using to make that judgment. And that information is, not going to be, probably not going to be coming from, it's not coming from a journal article. It's coming from what they're talking to their peers about, what information they're reading on Facebook. Facebook is, I mean, when we've done surveys in our sort of rural community in which we work here in KZN, big sources of information are Facebook and other social media platforms. So it's an important, and the problem with social media is that, I had mentioned in the cascade, the influences of cognitive biases and sort of heuristics that influence how we process information and what we end up believing. Those algorithms are just perfectly set to play into confirmation biases and, other biases we have. And so I think if someone's making an assessment about their risk, they're going to make that based on the information they're using. And, if that information says, you don't have to worry about it. It's, it's HIV is the problem of people who are sexually deviant or sexually promiscuous. If you don't consider yourself sexually promiscuous or sexually deviant, you are not going to even engage in HIV. You're not really going to listen to HIV messaging, or you may hear the HIV messaging and just sort of, throw it out, not keep it in your brain, not use that cognitive energy to process that information. But then also, if you're making an assessment about costs and benefits, if the information you're using to make that evaluation is, if we think of women in our society, and most of them are still very much dependent on partners, if the information you're making, if you're using an evaluation to say, well, I could be on PrEP, but then if my partner finds out, it may imply that I mistrust him. And so I could lose that relationship. That information is going to probably lead you to make the decision that I just won't engage in it because it's not worth losing an important relationship. Mm-hmm. So yes, I do think that it will play a different part in the information at the different stages that you use to make that decision will influence greatly whether or not you continue or not.
Yeah, no, thank you. Very interesting. And maybe just a quick follow-up. I know you mentioned sort of, I don't know, has there been any work done or is, around sort of switching to or leaving enough time or encouraging the switch from that type 1 to type 2 thinking around adopting health behaviors or interventions?
So I mean, I don't think so. A lot of this is sort of research on system 1 thinking, system 2 thinking is really around lots of experimental work around how how we make decisions and how we're forced to make decisions very quickly versus decisions that we would make more deliberatively. So I think it is an area that requires more investigation, but yes, I think I mean, if you think about it, with the work that's done, often the research and the literature and the evidence that we have is that there are lots of sort of negative connotations with HIV. We know that people have lots of sort of negative feelings and negative affect towards HIV. I've done some work myself where we've looked at association activities, where we say to people, we give you a word and then we want to hear what your associations with that word are. And that's looking at, if you say HIV, someone's like, oh, a sexual deviant, a gay person, a sex worker or prostitute, that's what they'll say. And, those are all sort of very immediate, very system 1 reactions to these, to HIV, and those are overwhelmingly negative. And I would argue that if you have very negative associations with HIV and what it means, your engagement with HIV, anything, is going to be harder to sort of influence. Whereas, we know that if people have members of their families or partners that are HIV positive, there's a general sort of greater sense of understanding and empathy and sort of more positive feelings towards it. And so those positive feelings then may affect make positive associations and make you more willing to then continue to think about whether or not you should be engaging in whatever action is trying to be instilled in you, or whatever action is trying to be facilitated. Whereas if you sit people down and talk to them about, pointed out, so maybe like Devorah was saying, that shared decision process with a healthcare worker, if you're sitting down and making a sort of deliberative conversation about, look, these are the costs and benefits, write down your costs and benefits. Do you see that this cost could be offset by, taking PrEP, or we can help you offset this cost by doing that. So it eliminates those costs. And so actually the decision to use PrEP is a great one. You see how it could work for you. It has a lot more benefits than costs. Then that more deliberative process where you're making that decision or helping the person to make a decision based on sort of accurate information or more objective information, that's system 2 thinking. And so that is a very powerful and helpful tool, and we've seen that work in interventions before.
Fantastic. Thank you so much. Very interesting.
Thanks, Alex, for the questions. Are there any other questions for Hilton? I don't see anything in the chat. Anyone else? Oh, Kate, go ahead.
I just wanted to ask where we can find your paper. Has it been published already, or is it in the process?
No, it's been published, so I can send it. Well, Lucia has it, otherwise I can resend it to her. And then I don't know if it's easy for you, Lucia, to send it out to everyone.
I can send it out. I'll put it on this chat.
There
I'll try and do it before we finish. Otherwise, Kate, if you can't get it, then let me know and I can send it to you. It is online. It's Decision Making Cascade, and Hilton is the primary author. Yeah, go and check it out. That would be great. Thanks, everybody. Thank you so much, Hilton, for both agreeing to present and for doing such a great job. It was really nice to have you to present. And thanks everyone for joining us and for great questions. For those that want to continue the conversation, Hilton shared his email address, and I'm happy to link you up with him as well. And I hope you all have a lovely Thursday afternoon.
Thank you.
Thanks everyone.
Thank you.
Bye.
Bye.
Cheers. Bye.
Bye.